lucky to have Dr. Anoop with us. Dr. Anoop, some of you guys may already know, Dr. Anoop is fundamental really for our SIMMAN and emergency medicine training for our PLAB2 Academy Plus program. So if you guys are coming tomorrow or you're coming in the next few months, you'll be meeting Dr. Anoop at the SIMMAN day that we do as part of the academy. But obviously he's got lots of other experience and lots of other roles, as well as a very senior emergency medicine registrar, almost close to the tipping point of moving into consultant stage. It's on the horizon. Every time we see him, we're counting down the days, how many are left. Moving to the UK in 2017, done lots of additional training in the field of emergency medicine. Very, very big interest in medical education. And we're very, very lucky. This is his third year, I think, in a row of doing this particular talk for us at this conference. I'm going to hand over to Dr. Anoop and make him the host for the next session. Again, thank you so much, Dr. Anoop, for coming on board.
Good morning, everyone. Thanks, Aman and Pooja, for this opportunity. I hope you guys are keeping well. So I'm Anoop. I'm one of the emergency medicine trainees in the South. This is my last year of my training. I finished my undergraduation and post-graduation from India, completed my MRChem, which is a membership exam for emergency medicine in 2016, moved to UK in 2017, and my first job was a senior clinical fellow in emergency medicine in one of the hospitals in east of England. Subsequently, I applied for training numbers in ST1 and ST3 and got successful in both, and I opted to start from ST1 training, which I commenced in 2018 in the south of England. During my training, I've also been a part of the emergency medicine trainee associations, and I've also been the rep for ACCS and exams committee from 2021 to 2023. I moved to the UK using the specialist pathway. So I finished my MRChem and then moved to the UK. My department in India had all the guidelines based on the UK guidelines like NICE and SIGN, so it was a bit easier for me to get accustomed to the NHS system. However, when I was waiting for my occupational clearance for the first 2 weeks after moving to the UK, I utilized the time and did some shadowing shifts in my department, just observing to get to know how the system works. Subsequently, I did 1 week of supernumerary shifts for me to get accustomed, and then it was really easy for me to get into the system. So my suggestion for you guys would be start at a non-training post and at a junior post for you to have some time to get accustomed to the system, because it's the system that matters. And once you know how the system works, then it will be easy for you to fly through. So my suggestion, and you could have seen in lots of social media posts and stuff, the suggestion from all the senior IMGs are spend some time in the system before you jump into the training, because that's a huge responsibility that you're taking. So starting from the beginning, the relocation to the UK, as you may be all aware of it, the most common one is the PLAB pathway, where you give your PLAB 1 and PLAB 2 and get your GMC registration. The other options are the post-graduation pathway, where you complete your membership exams or any post-graduation degrees that is recognized by the GMC, and you subsequently obtain the GMC registrations and get into the system. The other option is your MTI pathway, which is your medical training initiative, but now the seats are becoming less and less for MTI, and I wouldn't suggest the MTI pathway for now. So the most common ones are the PLAB and the post-graduation pathway. So why emergency medicine? Lots of good things. So we are normally known as generalists because we've got a broad knowledge of most of the specialties, because we get patients from various specialties or various acuity of patients in the emergency departments, from trauma to infectious diseases, toxicology, etc. We see a broad spectrum of various diseases. There is also an opportunity for you to concentrate on research if you're more interested in research. It can be a clinical research like in trauma care, cardiac care, pediatric emergency medicine, toxicology, etc. You can also do some research topics on epidemiological things like substance or recreational drug use and abuse, public health interventions. You can also concentrate on health service research like ED operations, education and training research like medical educations and simulation. And the hot topic for now is the research using the AI in emergency medicine. So if you're interested, you can also refer to the Royal College of Emergency Medicine website, which has got lots of resources for you to how to improve your research opportunities in emergency medicine. On a daily basis, we also get to do lots of procedures, from intubations, chest tubes, joint reductions, blocks, etc. When you are a part of the emergency medicine team on a daily basis, you get to communicate with lots and lots of people from various specialties, which improves your communication standards. You get an opportunity to communicate to almost most of the specialties in the hospital. You also get to improve your leadership capabilities, and like in a trauma patient, in a trauma scenario and stuff. Mostly, the trauma team leader will be a senior emergency physician, so you get to lead the entire trauma team or the cardiac arrest team, etc. Uh, some people agree, some people don't disagree, but I think there is a good work-life balance happening when you're in emergency medicine, because you have got various shift patterns rather than a daily 9 to 5 jobs. And the good thing I personally like about emergency medicine is some of the hospitals run follow-up clinics, but most of them we don't run follow-up clinics, and we don't need to run clinics on our own. But some of them they do, like the minor injury clinics, so it also gives us a good work-life balance. There's also an opportunity for improving your management capabilities, like you can become the clinical director, you can become the governance lead, administrative lead, regional director, a research director. You can also, some of the departments they do clinical trials, and you can also be a clinical trials manager. And currently, again, one of the hot topics coming up is the health informatics, which is again an opportunity to improve your management. So it's a lot to do in emergency medicine, guys. A quick overview of how the emergency department works in the UK. There are 3 different types of ED, most commonly. So as you all know, UK is divided into different deaneries, or the regions or counties, you could say. So every region will have one major trauma center, and the other hospitals will be trauma units, and then you have small emergency departments. Major trauma centers will be covering the entire deanery area, and most of the major traumas, your level 1 traumas like uh, uh, brain injuries or your cardiothoracics or your vascular injuries, and they'll all be capable of handling those. So in your deanery, whichever area you are in, if the patient is injured, they will be transported to the major trauma center subsequently. The trauma units are the second type of EDs. They are capable of handling traumas, but not major traumas. So they will be able to stabilize the traumas, and if they need some specialist interventions, they will be eventually transferred to the major trauma centers. The third type of emergency department is they don't take traumas, or sometimes they also they work in conjugation with the UTCs, or the urgent treatment centers, where you see some minor illnesses and some minor injuries. ED layout, as most of you may have been aware of it. So basically, in ED, you have the triage area. So the patients can come either by ambulance, or the patients can walk in or make themselves by their own transport. When they come in, when they walk in, or they make their way by themselves, then they get triaged by a senior emergency nurse. Sometimes you might have a senior emergency physician or a consultant there. And based on their category, if they are very sick, they'll go into resus or the priority 1 area. If they are okay and just need some intervention, they'll go into the majors area. If they're peds, they get triaged into peds, or if they are minor injuries, they get triaged into minor injuries. There's also a separate ambulance receiving area. There are 2 types of patients coming through ambulance. One are the very, very sick patients. If they're very sick, they get pre-alerted to the ED through the phone. It is just time for us to prepare things. For example, if it's a major trauma requiring lots of blood and stuff, they pre-alert us, and then we get the team and all the equipment and resources ready to receive them. And sometimes it is also useful for us to know, so that we can create some spaces. And you also have an area called the pit stop, or the rapid assessment or treat and triage area, where from the triage, the patient goes to the pit stop, where the patient gets some immediate interventions. For example, if the patient is septic, then the antibiotics gets prescribed, bloods are all done. If the patient needs a quick imaging of his head to rule out any bleed, then it gets booked in pit stop. And after the patient has been pit stopped, then they get moved to different areas, like your majors, or which is your priority 2 areas, minors or peds. Currently, most of the hospitals have minor injuries as a team as a part of their ED, but some of the hospitals they do it off-site, so they have a different area where it's exclusively for minors. Shift patterns. Most of the hospitals have these basic shift patterns. So either it can be an 8-hour shift or a 10-hour shift. It's called a morning or early, where you start at 8 o'clock in the morning and you finish it around 5 o'clock or 6 o'clock. Then you have a late, which starts at around 1 o'clock or 2 o'clock and finishes at around 10 o'clock. Then you have the twilight shift, which some hospitals do it up to midnight, but some of the hospitals they do like they start from for example 4 or 5 in the evening, and they go up to 2 o'clock in the night. And then you have the night shifts, which is basically night 10 o'clock to morning 8 o'clock. You will not have a continuous shift, so you will have a variety of shifts in a month, and you'll get to do any of those shifts. Moving on to the most important part, which is your emergency medicine training in the United Kingdom. So you can become an EM consultant either through training or a non-training pathway. If you're applying through a non-training, it'll be through your CSER pathway, or which the GMC have renamed as a portfolio pathway recently. If you're coming to training, either you can start from ST1 or you can start from ST3 or ST4. If you're starting from ST1, then you, at the end of your training, you get what is called your CCT, which is your certification of completion of training. If you have done minimum 5 years of training in emergency medicine, then the GMC would give you a CCT. If you have done less than 5 years, then you get what is known as the CSER CP. Further details will be available on the GMC website, which you can refer to. When you're applying for EM training, you can do as a coupled or an uncoupled training. For instance, you are applying for ST1 emergency medicine training post. Okay, it will ask you whether you want to do a coupled or an uncoupled training. If you're opting for a coupled training, then it's a straight run-through training. You do ST1, ST2, ST3, ST4, ST5, and ST6. You don't need to come through the interview process or go through the interview process once again. However, if you wish to do an uncoupled training, then you do ST1, ST2, and ST3, and then again you reapply for ST4 training again, go through this interview process. That's called an uncoupled training. There are pros and cons for each, and it all depends on individual circumstances. EM training, as I mentioned, you either start from ACCS, which is your ST1 training, which is your acute common care STEM, or you start from ST3, or a DREAM pathway. So DREAM is nothing but defined route of entry into emergency medicine. For instance, you have done a core surgical training, and then you feel that, no, I want to switch my specialties to emergency medicine, then that specialty, then this pathway is better for you to enter into emergency medicine training. Some of them have got lots of experience before, so they also opt for this DREAM pathway. The next one is, as I mentioned, you can also straightly apply for ST4 training number, which is your HST training, provided you are able to demonstrate all the workplace-based assessments or all the competencies being signed off for ST1, 2, and 3, then you can directly apply for ST4 training. As I mentioned, EM is a 6-year training program. Your ACCS is your acute common care STEM, which is from ST1 to ST2, and then ST3 will be your intermediate training, and your HST, which is your higher specialty training, is from ST4 to ST6. So ST1 and 2, which is your acute common care STEM, where you get to do 6 months each of emergency medicine, acute medicine, intensive care medicine, and anesthesia. Your ST3 will be covering, will be more focused on your pediatric emergency medicine and minor injuries or musculoskeletal trauma. And ST4 to 6, where it's based most on your higher specialty emergency medicine training, where you get to improve your management skills, your leadership skills, etc. The Royal College of Emergency Medicine will be monitoring you, and it's responsible for all its exams, and it conducts all your exams. You will be reporting to your local training program director, and your Health Education of England of that deanery oversees your training. You will have yearly ARCPs, which you say as an annual review of complete progression, so how you're doing it, and then at every year you get assessed and see whether you are meeting all your standards of training. So that will be monitored by your Health Education of England of that specific deanery that you are working in. Exams wise, so your first part, which is from ST1, 2, and 3, you get to do 3 exams, which is your MRChem, which is your membership exam, member of Royal College of Emergency Medicine. So you have the primary, intermediate, which are both are single-based answers, and then you have your OSCE. You need to complete your MRChem before you are able to progress to ST4. If you are in your run-through training and you are not able to complete your MRChem before you enter into ST4, and you'll be given some additional time to complete it before you progress to ST4. For your higher specialty training, you have again 2 exams, which is your Fellow of Royal College of Emergency Medicine. The first exam is called your FRChem final single best answer questions, and then the next one will be your OSCE. It's quite common that people now, they sub-specialize or dual specialize in 2 specialties. With regards to emergency medicine, you can subspecialize in PEM, which is your pre-hospital emergency medicine. It's quite competitive. There are around only 15 to 20 seats that open per year for the entire country, including Scotland and Wales. Isolated, it is 1 year training program, but sometimes it is coupled with the emergency medicine trainings. So it comes to 2 years. There are 2 exams when you apply for FEM. One is the Diploma in Immediate Medical Care, and then you also have to do the Fellowship in Immediate Medical Care, which is the FIMC. Currently, the GMC have changed its rules. You can apply for your pre-hospital emergency medicine even after you've completed or you've CCT'd in emergency medicine. The next one is your pediatric emergency medicine, which is your PEM. Again, it's an isolated 1 year training program where you get to spend 6 months in acute pediatric atmosphere, like pediatric ICU and stuff, and another 6 months in pediatric wards and pediatric emergency department. There are no exams for PEM as of now. It is all competencies based. Again, GMC have changed the rules now. Even after you complete your CCT in your emergency or finish your training in emergency medicine, you can apply for your pediatric emergency medicine training. The other common specialty is dual specialization in intensive care medicine. So for intensive care medicine, you have to give your final FICM exams. As per the Faculty of Intensive Care Medicine, you have to apply for your intensive care medicine training post before you complete your ST5 training. So you are not eligible to apply after you've completed ST5, and the earlier you can apply is means during your ST4 period you can apply for it. Or just when you're about to finish your ST3, then you can apply for intensive care medicine. Coming to the recruitment timeline, you guys are lucky now. So now, as you know, for the past few years, the rules have changed that all the IMGs are eligible to apply for round 1. If you are interested in ACCS emergency medicine and you want to apply for ST1 post, it is a national recruitment and the adverts will come about in November. Like for example, for next August 2024 intake, the adverts for round 1 will be opening in November. So keep an eye out for it. And then you'll be called for an interview by Feb or March. That's the approximate timeline. Depending upon the number of vacancies and the seats filled, you may or may not have round 2. And if you have it, it'll be around March or April. If you're interested in applying for your DREAM or your HST, that is your ST3 training number or your ST4 training number, then the round 1 opens around in Feb, March, and then based on the vacancies, you might or may not have, you may or may not have round 2. So HCC emergency medicine, you might all be aware of the CREST form, which needs to be completed. Then you start building up your portfolios. You give your MSRA exam. Then you'll be called for an interview once you're successful in your MSRA exams. And once you're successful in an interview, you get a training number. This is a quick whiz through of your person specifications, which is available in your Health Education of England person specification website. This is the person specifications for acute common care STEM emergency medicine ST1. I'll just quickly go through this. If you look into this entry criteria, there are essential criteria, okay, and then it'll say when you're eligible, fitness to practice, language skills, and health. And then if you go down, can you see that you will have for the selection criteria, you should have all the essential criterias and try to get as much as desirable criteria as possible. Having said that, I would be very wary that there are lots of easy tick boxes you can achieve in the desirable criteria. For example, you can do your advanced life support skills like your ALS, APLS, and some trauma courses like your ATLS or ETC. You can do some patient safety projects. You can do some clinical improvement and stuff. Some of them I've seen, they quickly rush in, they spend around 10,000 or 12,000 pounds because it is mentioned in the desirable criteria that you get a mark for BSc or BA or some kind of additional qualifications. Please do not do that. If you feel that you can do it, like for example, you've got a passion for medical education and you want to do a degree in medical education, but go for it. But just for the interview purposes, I wouldn't suggest that you spend around 10,000 or 12,000 pounds, drain your finances and do this. Remember, there are lots of other quick tick boxes which you can achieve without minting out lots of money. You can do some management and leadership in your department. Your consultants will guide you. You can also do lots of teachings which are available. You can do lots of extracurricular activities, achievements specific to the specialty. You can attend lots of training courses. These are all desirable criteria. So you don't need to rush in and do the additional qualifications. But if you're interested in, and you've got a passion for it, like let's say I'm interested in simulation, I wanted to, do some simulations, then go for it. Otherwise, think twice. Coming to the competition ratios, yes, it is getting competitive. So as you are all aware, most of you would have read the 2024 NHS plan, which has been out recently. There will be no increase in training seats. So if you look into the number of training posts, it's been consistently around 361, 360 range, okay, since 2018. So if you look into it, the recent ones, I don't have the 2020, 2023 one, which will be published next year, but 2022, if you could see, there were for 361 posts, you had around 1,600 applicants, and the competition ratio is 4.45. So around 5 people competing for one spot. This is for ST1 emergency medicine. If you go for ST3 emergency medicine, then you have in 2022, you have around 6 people competing for one spot, and you just have got only 40 seats for ST3 emergency medicine, including your dream. Your ST4, again, it's only 65, and around two people are competing for one spot. Okay, and I was told that for 2023, the competition ratios have increased more for ST1 and ST3 and ST4. Okay, so it is getting tougher. But the good thing is that as IMGs, we are eligible to apply for round 1, so you can apply and be successful if you have your portfolio ready. Yes, we've got some tough competition. It is possible. Okay. Coming to training and non-training, there are pros and cons for each, and as I said, it all depends on your individual circumstances. I just would like to mention some pros for your training number. If you are in training, you get adequate support, you're being continuously monitored, and every year you have got your ARCP, so they review whether you need additional help or where you can improve and stuff, so you have that constant feedback going on. And when you are a part of your training, you get to have a taste of different types of EDs. Okay, in your training, you will have at least 6 months of your major trauma experience during your ST4 to ST6 years, minimum of 6 months. So that's a good thing. You also get posted in your district general hospitals or smaller EDs where you get to see more minor cases and stuff. It'll be a smooth transition. So you don't, and if you're applying for run-through training, so you don't need to apply for interviews again. So you start from ST1 and then finish in ST6. It's a straight run-through training. As a part of your training, you have an opportunity to go less than full time. You can go as low as 60% also. And there is also an opportunity that the training also helps you with out of program things. I'll be explaining about the out of program in the next slide. And moreover, and in a training, you get supported and you get funded for most of your mandatory courses. So that's another good thing. Coming to the out of program. So basically, if you're in a training program and if you're interested to something, you can pause your training program, do that specific thing and come back to it later. There are various types of OP, or which you say as an out of program. If you're interested in out of program of doing something like MSF or humanitarian work, you can opt for out of program experience, where you inform your deanery well in advance. It depends on, they say at least 6 to 8 months in advance. Get permission from your TPD and say, okay, I'm going out for 6 months, I'm going out for a year, I need to do something extra, and then I'll come back. And if they're happy, they'll give you permission. The next one is your out of program research. You can take an year out, do some research with NIHR, like Sheffield, Manchester, Southampton. Lots of big hospitals are promoting research. You can do that and come back to your training later. You also have out of program training. For instance, let's say you finished ST1, ST2, and ST3, and then you wanted to do some emergency medicine training in Australia, work in Australia, and then come back to the UK. For the out of program training, you need to get approved by the GMC. So you need to tell your TPD or your deanery saying that you're going to work in Australia for 24 months. These are the job description and stuff, and you'll be monitored by a consultant. And once your training program director approves, it will be sent to the GMC, and the GMC will tell you, out of that 12 months or 24 months in Australia, how many months of it will be considered for your training. So you need to get it approved by the GMC before it has been approved as out of program training. Otherwise, it will be approved as only out of program experience. It's only the out of program training that needs GMC approval. The remaining all the OOPs just need your local deanery approval or your training program director approval. The other thing is that you just wanted to have a bit of a career break and then come back later. You can opt for OOPSI, which is your out of program career break, or you can also opt for you can pause your training for some time and then come back later, which is called your out of program pause. Okay, so there are lots of options when you're in training. My quick tips for obtaining an emergency medicine training number. As I said, spend enough time in the system. Okay, there is no hurry. Okay, so spend enough time in the system to get oriented to the NHS, the local systems, how the system works, etc. During your non-training post, you will be allotted an educational or clinical supervisor. Meet with them early. Okay, tell them what are you planning to do. Okay, make a personal development plan. Okay, have a discussion with them saying, okay, how to achieve your how to get your crest form signed off. Okay, how to get your portfolio built up, etc. Then I would suggest that you download your crest form and your person specifications and keep it ready for it. So you need to know what are the desirable and the essential criteria so that you start working on it from day one after you get accustomed to the NHS. Okay. So first initial few months, get accustomed to the NHS. Do not think too much, too big. And then once you're accustomed to the NHS and you're confident of working independently, then start concentrating on your portfolio. Also speak to them about your audits, your quality improvement projects. So all these are quick tick boxes for your desirable criteria in emergency medicine training number. Be a part of your teaching. You can teach your juniors, you can teach your colleagues. You can also be teaching your allied healthcare professionals like your nurses, nursing staff, your ACPs, your ENPs, etc. So utilize that opportunity, but make sure that once you've done a session, either you get uh, an assessment by your consultant or your registrar, or also get some feedback from the participants, from the learners, so that one, it gives you an idea of how much you've delivered to them. Also, it also gives you an opportunity to fill in the areas that you wanted to improve. Portfolio, as I said, keep improving your portfolio. Like for example, if you're aiming for this November, start working earlier and just get all your portfolio ready at least a month before your adverts come up so that you are ready and ready to go. Once you've done that, start doing, and once you're successful in your MSRA exams and stuff, start doing some mock interviews with your consultants and your senior registrars. The other tip I would suggest is speak to the new ST1s and ST2s, because they are the ones who have recently done the interviews. They might give you some tips or any changes that that has happened when they applied for this emergency medicine training. Okay, so have a chat with the new ST1s and ST2s who have recently done the interviews. They might give you some tips. Your ST1 or ACCS ST1 EM recruitment, they consider 40% of your MSRA marks. And then once you're successful in MSRA, you will be invited for interviews where your interview counts for 60% of your assessment. Currently, your interview is online on Microsoft Teams. There may be 2 or 3 panel members, and the interview lasts for around 30 minutes. You might have questions on your commitment to the specialty, about your teaching experiences, and examples of some team behavior where you have been a team member, or what you have witnessed or how you have contributed. They would like to know about that stories and real experiences. So the tip here is more mock interviews, practice well, then you'll be able to achieve it. Okay. Further reading, as I said, you can refer to the Royal College of Emergency Medicine website, which will give you lots of information about the training process and stuff. You can also go for the Health Education of England Emergency Medicine Training person specifications. And you can also look into the timelines on your ORIEL website to see when the adverts will be on. That's it from me. Hope you guys have got an insight of the emergency medicine training and an overview of emergency medicine in the United Kingdom.
Yeah, really good. Thank you so much. And as always, crisp, to the point, full of information. And actually, a lot of the common queries that we tend to get asked, you've covered in this talk today. So yeah, really useful. There's been quite a few questions pinging up in the chat on our side. Dr. Pooja has been busy replying to some of them directly herself. Anoop, I'll go through a couple of questions that I think
Yeah.
are more general here. And then maybe if you could just do a quick scroll at the end just to see if there's any particular ones that are more kind of specific to answer directly that may not be useful to everybody on the conference. But one particularly stood out. This is about the future of emergency medicine training. Emergency medicine training is my love. Recently starting an FY2 level job in orthopedics with overlapping ED shifts. Really concerned about minor injuries being taken over by ENPs. I understand they're crucial for the system to go forward, and ED will collapse without them. But I feel that I'm losing big opportunities to learn about things like wound management, X-ray interpretation. What's your opinion on this relating to the training in the future, and what's coming up for EM training going forward?
Yes, I do understand that's been a concern now from among the trainees about that you don't get enough time to spend in your minor injuries. However, the Royal College of Emergency Medicine have given exclusively 8 hours per week of um, educational development time. So you have 8 hours per week of educational development time when you are ST4 to ST8, sorry, ST6, sorry. So those 3 years, you can use your 8 hours and then do shifts in where you feel that you need more training. For example, it can be a minor injuries, it can be a pediatrics, etc. And you can also book that couple of shifts. For example, you can do 3 or 4 shifts continuously in minor injuries to gain exposure. And that's what we have been doing. Yes, it has been moving away, but sometimes during the nights, and if you're working in a small DGHS, then you will have to see minor injuries. So that's reason in training, you get a taste of every different EDs. Whereas in a major trauma centers, you always have 24/7 ENPs covering. So you might not have that opportunity. So if you're working in a major trauma center, I would suggest use your 8 hours to do some minor injury shifts. But if you're working in a DGH, it comes as a part of your daily duties or clinical work. In that case, you can use those 8 hours to do something extra, like, for example, seeing ENT emergencies, attending ENT clinics, or doing some PEDS, etc. I hope that answers the question.
Yeah, fantastic. Um, I think we have a couple of questions coming in about people kind of thinking 2, 3, 4 steps down the line. So people are asking a little bit about if you do training in the UK, what's the scope and acceptance of UK A&E training in India, Australia, and the Middle East going forward?
Okay, to keep it simple, down the line, no one knows what happens because things keep changing. Okay, currently, if you are a CCT from United Kingdom, you can apply for Australia, you can apply for Middle East. Okay, you can apply for South Africa, New Zealand, and Canada. Okay, some of the Canadian universities they accept direct CCTs from UK, but down the lane, in 5 or 6 years, no one knows how the rules are going to change. So I would suggest that yes, you can have a plan, but be aware that it is a discretion of that medical council to change its rules when they require.
Perfect. I think there's a couple of queries about anesthesia come in. Is that something that you know a little bit about, or would you
What,
know that field?
what's the question about anesthesia? Sorry.
Um, I've completed my postgrad in India and I'm planning to get into the NHS system via PLAB. Actually, this is a doctor who's coming to the academy next week, so you'll meet her anyway on Wednesday. But not sure how to get into the particular department. I guess anesthetic training program. I completed my 3-year PG with 1 year experience post PG. So how would my pathway go if I want to end up being an anaesthetist? And,
The
and just bear in mind, you'll be meeting this doctor on Wednesday, so you can go into more depth maybe then. But just as a general overview, if you know about
Yeah.
anesthetic
So
training.
the anesthetic training is again a bit different. It is more competitive than ED. Okay. You currently they have removed the ACCS anesthetic, so you just have your core anesthetic training, which will be for 3 years, and then you'll have to come out and apply for your specialty anesthetic training. It's a 7-year training program, and again you can refer to RCOA website and your NHS HE anesthetic person specifications. But it is more competitive than ED, and they also have that bit of a thing saying that if you have more than a specific months of experience in anesthesia, then you cannot apply for your junior post, so you'll have to apply for your senior post. So you'll have to, look into the person specifications very carefully.
Fantastic. Fantastic. And yeah, it's interesting to know that anesthetics is more competitive than ED. I didn't realize it was that way around. But yeah, important to realize. And like I said, this doctor I won't name, but you'll be meeting her on Wednesday, and so you can probably run through any queries that you have with her on that day. There's been a lot of questions about MSRA in general and how to prepare and things. We'll be covering MSRA in much more detail in the general practice talk that I'll be doing before lunch. So I'll leave those queries to then. Was there anything that you spotted that you want to jump in before we move on to the next talk?
No, not really. I think Anoop gave quite a detailed talk, and it's always useful having you around, Anoop. So thank you ever so much for your talk and for your insights. I think most of the questions have been covered in the chat. But yes, huge thank you, Anoop. For those of you, as we've mentioned before, Dr. Anoop is a key part of our academy, and he gives a huge amount of insight into acute medical scenarios. So we're ever so grateful for him giving up his time in his busy schedule to come and give you guys advice. So thanks a lot, Anoop.
Thank you so much, Aman and Pooja. Hope you guys enjoyed it. Enjoy the rest of the day. Thank you.
Great. Thanks.
Yes.
We'll see you on Wednesday for
Bye.
Sim Monday.
Thank you.
Take care. Thank you.